So I've got an interesting CT brain for you today. This is a 50-year-old gentleman who presented to emergency complaining of nausea, tinnitus and vertigo after slipping and falling in the shallow waters down at 13th Beach. Let's start by scanning through his axial images and just having a quick look through, looking for any striking abnormalities or gross pathology. And you can see that there's really nothing eye-catching. There are no big bleeds, there are no hyperdense lesions at all. We'll go back to the start and start having a little look through a little bit more slowly. And I'll draw your attention to the anterior aspect of this left frontal lobe here. You can see that there's a hypodense lesion sitting between the brain parenchyma and the skull. Similarly, we've got a couple more of them back sitting along the tentorium in the posterior fossa here. And these are actually little locules of gas consistent with a pneumocephalus. Now, the presence of gas inside the skull is always pathologic, and it suggests that there's a communication between the inside of the skull and the outside world. Before we go looking for that, we need to consider the significance of having gas inside the skull as it relates to intracranial pressure. And this is for all the medical students and first parters. We're going to have a quick review of the Munro-Kelly doctrine. So the Munro-Kelly doctrine states that the skull is a rigid box which can't increase in volume. Inside that box, there are three main components, which is the brain, the blood, and the cerebrospinal fluid. Now, if there's an increase in any one of these components, then the others attempt to compensate by reducing their volume. But there reaches a point where they can no longer compensate, and that's when we develop changes in pressure and increased cranial pressure, ultimately leading to things like herniation. Similar to an intracranial hemorrhage, adding in gas to the Munro-Kelly doctrine means that we've got another volume-occupying substance that's going to force out some blood or some CSF, or, if the pressure gets high enough, some brain tissue. So let's have a look through and see if we've got any evidence of that so far. So scanning through, this is probably a good image. So, looking for signs of mass effect, we've got a nice straight midline with no significant shift. We have ventricles that are symmetrical, not compressed, and you can see the occipital horns back here as well. And finally, we have sulci and gyri on both sides of the skull, which is quite a normal looking brain. So apart from a small amount of loss at the anterior aspect of this frontal lobe, there's really not much in the way of mass effect from this gas. Let's move through and have a little look at the bony windows, and we'll see if we can figure out where this gas is coming from. So gas inside the skull may not be an unexpected finding in neurosurgical patients who've recently had a brain biopsy or a craniotomy, for example, but in the setting of trauma, it makes us start to think about skull fractures. Let's have a look through these bony windows and see if we can see any skull fractures that might account for this gas inside the skull. You can see that the gas locules are much better seen on these bony windows. And again, we've got lots and lots of gas tracking up along the tentorium here. We've also got some gas around the cisterna. We'll keep tracking up. You can really get a sense of the depth of this anterior collection here. It goes right up towards the vertex. But look at the skull. There's no depressed skull fragments. There's no obvious breaks that we're seeing. And look, we've even got a couple more little locules of gas over here. Let's go back through. We'll have another look. There's really no skull fractures that are jumping out at us. So we know we've got gas, we know we've had trauma, but we can't see a fracture of the cranial vault. This is where we need to start thinking about base of skull fractures, which, if you're anything like me, is something that I am terrible at finding. But we're going to try and find a few basic tips to raise your suspicion of a base of skull fracture. So where I like to start is at the sphenoid sinus, and you can see here that we've got quite a significant fluid level, which is consistent with blood. And that is a good sign that there's a base of skull fracture in play. We've got blood filling up the sphenoid sinus. Looking to other normally air occupying spaces, we can have a look at the mastoid air cells. If we scroll down, we can see over here on the left-hand side, they're looking fairly normal and clear, but on the right, we've got fluid levels again within these air cells. That would suggest that perhaps the base of skull fracture is on the right side of the skull and communicating with these mastoid air cells. So let's have a closer look. Moving through, some very handy radiologist arrows. So, looking here at the cochlea, you can see that the radiologist here has pointed out this small locule of gas within the cochlea. So that would certainly account for the feelings of tinnitus and vertigo that this patient's describing. And there's also a small fracture that's moving through the petrous part of the temporal bone here and in towards the jugular foramen. It's probably better seen though looking at the coronal images, so let's have a look at those. So looking at these coronal images, let's scan through and have a look. And again, we've got that quite significant fluid level in the sphenoid sinus. Moving through, we're going to see the ear canal and the middle ear now. And I'll draw your attention towards this. So you can see, let's look at the left to start with, that we have this snail shell type structure that is sitting there in the inner ear. Now that's actually the cochlea visible on CT. And if you have a look at the left cochlea, you can see that the internal aspect of it is the same density and the same colour as the rest of the brain parenchyma and tissues. But if we go over here and have a look at the right cochlea, again, you can make out that there's a black line of gas similar to the ear canal inside the cochlea there, and that's pathologic, so we don't expect to see that. Scanning through, you can much more clearly see that there is a breach here through the petrous part of the temporal bone, and that's moving all the way through. So this gentleman has a base of skull fracture which has resulted in quite significant pneumocephalus without any signs of tension, and he also seems to have involvement of the inner ear. So it's a pretty significant finding and one that we'd be needing to talk to our neurosurgical and ENT colleagues about in the near future.